It's magic too. We have, I think, maybe 700 or 800 people here today. So here we are in the post-pandemic, and we're all together for a really great cause. So I'm told by Dr. Mara Seier to say that I'm a late addition. My name is Matt Rizzo, and I'm the chair of the Department of Neurological Sciences. I also lead the Neurosciences Service Line and some other things. But it's great that you're all here. Probably you've had a chance to look through this amazingly spiffy agenda for our conference, Parkinson's Disease in 2023. And it's important that you're all here, patients and caregivers, experts in Parkinson's disease, people who really care. It's not just the science that helps conditions, it's the family relationships, the patient with a spouse, a husband or a wife. These sort of dyadic relationships are extremely important, and people affect each other's health. To have a great caregiver is to have a great outcome. To have a patient who understands the seriousness of their condition and how it affects their family is also important. So here we are. Parkinson's disease is maybe more prevalent than we thought. There might be 1 million people in the US now who have Parkinson's disease. It's probably the second most common neurodegenerative impairment after Alzheimer's disease, and it affects many patients, but as we see here, also the family members and the caregivers. Because of the demographic projections of how our population is evolving over the coming decades, there'll be more and more older people who are more at risk for developing Alzheimer's disease. It isn't just age, there are other risks like genetics and the environment. We'll get into that in a second. But, people have been working nationwide for some decades now to figure out what's the problem underlying Parkinson's disease, how do we diagnose it, and how do we treat it better. There's an important organization called the National Institutes of Health, which has a National Institute for Neurological Disorders, the NINDS. And on account of the deep research and the public commitment to providing money to sort of figure out what's going on, there have been treatments that have been quite effective for Parkinson's disease. An example of them is dopamine medications like Sitimet, which are pretty good at helping with some of the motor problems in Parkinson's disease, particularly early on. There are also surgical techniques with things like deep brain stimulation, which are also really important. But the thing is, there's no medication yet that we know that cures Parkinson's disease. You can make it better. You can make it a chronic condition that people can manage and live with. But the thing is, the changes in Parkinson's disease tend to be progressive. Folks start out with tremors. They might be just on one side of the body, but they spread. There can be slowness of movement. There can be stiffness or rigidity. There can be impaired balance, and these things kind of add up. And they cause problems over time, and folks have trouble with walking and talking and swallowing. So these kind of problems can be a challenge over time. And then there are so-called non-motor features of the condition, and they include things like not sleeping too well, having changes in mood, having problems with a part of the nervous system called the autonomic nervous system that controls things like how your gut works, how your bladder works. So people can get constipated or have trouble with urination. They might have trouble with a loss of sense of smell. They might act out at night their dreams and become a little bit agitated about that, or they might have restless legs that keep them up and everybody else up. They can have trouble with digestion and salivation, excessive sweating. So it's a problem, and it's one that evolves over the course of a patient's illness and requires very skillful management, like the kind that we get from the superior world-class doctors that we have in our movement disorders division. But the bottom line is that we need more research to better understand and to characterize and to diagnose Parkinson's disease, preferably very early on, because if we have effective treatments, our chance of stemming the effects of the disease and maybe halting or even reversing it is greater if we know who has it. I want to mention that some of the treatments that we have, while they're great early on, later in the disease, if you're using them a lot, can be associated with excessive movements, these so-called dyskinesias, which are troublesome. And then, ultimately, people may become refractory to the medicines that we use, and so that they might have trouble with the medicine wearing off before the next dose. Some of you may be familiar with that. Drug resistance for some symptoms with, posture. Change in behavior where folks might not remember as well. They might even have bad dreams or hallucinations. They might have changes in their usual ability to sort of control their behavior. You've heard about things like excessive predilection for gambling and so forth. Anyway, so the bottom line is we need new therapies, we need new tools to diagnose Parkinson's disease, and we want to do it as early as possible so that we can avert some of these problems that I just mentioned to you. First of all, we have to understand what it is that we're dealing with, and it turns out that the factors that lead to Parkinson's disease are multidimensional. It's not just that there's problems with nerve cells in the brain that control motor functions. It's that they're responding to something. It could be the genetics of a person. It could be the environment that they live in. For example, in Nebraska, it appears that Parkinson's disease is much more prevalent than it is in other states. Why is this? Well, this is the sort of thing we want to drill into. We could look by zip code. We could look by proximity to factories or to bodies of water like the Platte River. Is it possible that there's some chemical in the environment that's interacting with the genetics of, say, people who came from Northern Europe, for example, that's causing this predilection for Parkinson's disease? We don't know, and we need to know, because knowing would give us some sort of actionable information that we could use to reduce the likelihood of getting Parkinson's disease. There are other things, like understanding the mechanisms where Parkinson's pathology might be transmitted in the brain. In Alzheimer's disease, there are these folded proteins that seem to propagate. It could be that something similar happens in Parkinson's disease. It could be that there's a role of inflammation, and maybe we need to be looking at that and treating with anti-inflammatory medications. Even more, there's a possibility of figuring out which medicines and which ways we use them can help individual patients. This is along the lines of something called personalized medicine. It's possible that by knowing all the factors about a patient, like their genetics, like the proteins in their body, like the nucleic acids that are circulating in their blood, like their demographics, what gender they are, how old they are, we might be able to say, hey, it's likely that this medicine is going to work in this patient better than it would in that patient. This kind of information also helps us with public health related to Parkinson's disease. So we want to know more about Parkinson's disease. We want to know more about therapies and freezing of gait. We want to know what we can do for the memory decline that might even end up causing dementia and having people move out of their home and they're not having agency and not being able to take care of themselves by themselves anymore. We want to know what's disrupting their sleep. We want to know why they have freezing of gait. We want to know why they have problems with dropping blood pressure when they stand up. So you've got to figure this out. We have to get beyond just the L-DOPA and just beyond the deep brain stimulation. But there are things you can do, and we need to be mindful of this, that don't have anything to do with medicine or surgery. And that includes how you live your life, whether you exercise, how much stress you get. There are new technologies that can help people out in the home and reduce the burden of some difficult tasks for them. There are smart homes, there are devices that people carry around with them, like their cell phones or watches that have things called accelerometers and gyroscopes in them, which tell you how much a person moves, where they move, what's the pattern of their sleep. Even if they're in bed, is the sleep that they're getting restorative sleep? So knowing what a patient does and having a comprehensive picture of who they are can help us direct our therapies better. So scientists are trying to unlock the mechanisms of Parkinson's disease. We here in Nebraska have our fingers on the pulse of what's going on. We keep track of national developments. We have clinical trials that are going on. We care a lot, and we're addressing Parkinson's in many ways, including the diagnosis, the biology, the treatment. And even more, I want to say that we need to be advocates. For the last 4 years, I've been the chair of the board of this thing called the American Brain Coalition, and it has about 150 or more different organizations, and many of them are patient advocacy organizations, and that includes Parkinson's disease, but it also includes other diseases that affect motion and memory and nerves, and some of them are pretty rare, and they're even named after families, and we're sorry for those families. But we think along the lines of a rising tide floats all boats. And so when we talk here today about improving the lives and the treatment and the diagnosis of Parkinson's disease, we're thinking more broadly about everybody. So thank you for being here. This is promising to be a great event. I'm just looking through the roster here of the excellent talks. I think you'll learn a lot. I think the discussion's going to be really valuable. So thanks again. People are everything, and you are great people, and we are grateful that you're here. Thanks.
Well, thank you very much. Welcome to everyone here in the Parkinson's family that we have. It's good to be together again. We thought that we might not get a capacity crowd, and boy, did we think wrong, because there is a real need to share this kind of information. We are very lucky to have Dr. Rizzo as our overall leader. He is a dynamo, as you can tell from his talk. He has assembled a wonderful team, and we are working as hard as we can. Even me in my retirement, I can't quite stop. There's so much more to do. I want to participate and help in any way I can, and let these new rising stars that you will be hearing from today tell you more. They are on the forefront, and I want you to meet them, and I want you to take notes. You are the reason that we are here. Actually, we would love to be able to eliminate Parkinson's disease from the list of diseases. We would like to then work on something else, and I know you would love that as well. You are the most important people in this room. I want to get a show of hands here. I was hoping that we could also enlist people today who are interested in studies, but we have rules and the Institutional Review Board. That's not going to be possible, but I would like a show of hands. How many in the audience here want to eliminate Parkinson's disease? Raise your hand. Okay, I think that's a pretty good showing of hands. We are searching to find a disease-modifying therapy, one that will slow down this illness. And as Dr. Rizzo said, this isn't just one illness. There are many genetic forms. There are many environmental causes. And we have to look at each one and find out which of these diseases is treated best by what medications. We do know the one thing that really matters is that if the patient, with the help of his family and all the support that we can give, the patient has to be in charge of his or her life. So take charge then. That's the reason that we are here. We're going to show you as much as we can about how to take charge of your life, and we are here to help you. It's hard to stop trying to help wonderful people like you, and I've run into people today that I haven't seen in years, some of them, and it's so good for them to be here. Take notes. We want you to ask questions. We want to answer your questions today, so please write down, scribble them, and when the question and answer periods come, please raise your hand. Exercise is the one thing that will slow down this disease. So if Parkinson's disease makes it harder to move, move more. It sounds crazy, but if you let it take over, you're going to do worse. And I see so many of you are still in the fight, and we are too. So I want to mention that we were the first state to have a registry. We were on the front edge, but so much more has come on now. We know so much more. There are more studies than we can do quite. But now our Parkinson's disease registry in Nebraska is being used by the Michael J. Fox Foundation and the Parkinson Study Group. And we were one of the founding members here at Nebraska with the Parkinson Study Group. And Ron Pfeiffer and Don Bennett were the ones that really started us out on this path. And we have to find, as Dr. Rizzo said, the diagnosis as early as possible. We need to prevent progression. So we need you to volunteer for studies, and we will keep you informed with your support groups, and we want to be working to make this a disease of the past. Someday we will. I just want to mention that we have more Parkinson's disease, as Dr. Rizzo. It appears in Nebraska, and so we are the great place to really find out all these causes and their solutions. So I am very honored to now introduce to you Mara Seier, who is at the center of our program now, and she happened to be taught by Dr. Ron Pfeiffer, and we met her. Some of us remember this. Dr. Torres and I and Amy Hellman had dinner with her in Berlin at an international meeting and had such a good time that she is now a member and an outstanding member of our department. So she has children of her own that are trick-or-treaters, and we saw pictures of them at the table this morning. And without any further delay, I would like to welcome Dr. Mara Seier to come up and begin diagnosis and management of Parkinson's disease. You want to come up?
Hello. Good morning. All right, let's see if I can figure out this. All right. So thank you for the great intro, both Dr. Rizzo and Dr. Bertoni, for kind of getting us started today. So now we're going to get into kind of some deeper dive on some topics. And I've been tasked with talking to you about the diagnosis and treatment of Parkinson's disease. I only have a half an hour to do so, so it will be kind of a quick overview, but I really wanted to highlight some things that I spend quite a bit of my time in clinic talking through with patients, because there's a lot of questions in this topic. So first off, how is Parkinson's disease diagnosed? So the term that we use is that Parkinson's disease is a clinical diagnosis. And what we mean when we say that is that we examine a patient, hear the symptoms that you've been having, and take that together in order to make the diagnosis, which in medicine is sometimes a tricky thing to visualize, because we're used to going to the doctor's office, we do a CAT scan or an X-ray, we get a blood test. For example, for diabetes, there's a certain number that once you cross that number, you've got diabetes, and on the other side, you don't. Well, for Parkinson's disease, it can be a little bit more subjective. And so sometimes you can see doctor after doctor and, what's this tremor, or what are the reasons that my movements are abnormal? And sometimes it can be a little bit of a delay of diagnosis for that reason. So usually that diagnosis is made by a neurologist or even a movement disorder neurologist, such as myself. So again, there's not one specific test that we can use to diagnose Parkinson's disease, but it's based upon the whole of the symptoms that are going on. So when you see your neurologist, what they should be doing is asking you about those symptoms and interviewing you about the things that you've been experiencing, as well as doing a really thorough neurological exam, which includes everything from just watching your facial expression, listen to how your voice sounds, having you do all the movements that we do with you in the neurology clinic, testing your strength, looking at your reflexes. All of that goes into our ability to make the diagnosis. So this is a very common question I get is, I noticed that you said the word Parkinsonism, but do I have Parkinson's disease? And so let's talk a little bit about that. So the term Parkinsonism is what I call sort of an umbrella term. So so what we mean when we say this is that we are seeing a collection of symptoms. The word Parkinsonism itself isn't a diagnosis, but a collection of symptoms, which we'll go over. So what we see when we use the word Parkinsonism is first and foremost slowness of movement. And the neurological term for that, or the fancy word that we use for that, is called bradykinesia. And that's just simply movement that is slowing down. And then not only just slowness of movement, but what we can see is disruption of kind of smooth movement that should be easy to do normally. And sometimes this can relay in halted movements or kind of freezing type of movements that get smaller and smaller the longer you try to do them. We also see in Parkinsonism rigidity, and that is stiffness of the limbs, usually the arms and legs, but we can also see rigidity in the neck. And how we evaluate for that is when we're doing passive range of motion. That's what we're evaluating for. And this is very common in Parkinsonism, and it's something that you might not necessarily pick up on yourself, but patients may experience feeling stiff and just that kind of inability to relax. And then another common part of Parkinsonism is a resting tremor. So that's a back and forth movement, usually in the hand, but can also happen in other parts of the body, that happens when you're fully relaxed, typically. So you're watching TV or you're driving, and then that tremor really starts acting up. So again, that Parkinsonism gets us, when we recognize that that's what's going on, that slowness of movement, that stiffness and the resting tremor, that brings us to kind of decision tree, that umbrella term of Parkinsonism. And underneath that are the diagnoses that we're trying to differentiate. So my job as a movement disorder, a Parkinson's neurologist, is to figure out what type of flavor of Parkinsonism you have. Now, the most common cause, and that's bringing in you guys today, is Parkinson's disease. But as you can see on this picture, that there are other types of disorders that can have similar symptoms, or that Parkinsonism, as well as medications that can mimic Parkinsonism. And then lastly, different things that the brain can be exposed to. So scarring in the brain, we call those vascular changes, having a head injury, or even after a viral syndrome. So what are the ways that you can recognize the Parkinson's disease symptoms, or we sometimes call these motor symptoms? What are the physical signs that you're watching out for? Well, a common one is smaller handwriting, and that again gets into the smallness of movement, and so people can get small, crampy handwriting. We call that micrographia. A quieter voice, kind of losing volume. Less facial expression. So family members often have noted to me that he didn't seem as excited, or he just sort of had a more blank look on the face. And that's, again, because those small facial muscles that give us our expressions get tampered down as well. And so then, not that the person is angry or unexcited, it's just that their face isn't emoting those emotions as well anymore. A slowing day of everyday activity. It just takes longer to do things. Issues with dexterity. So you might notice this with buttoning and zipping, doing two-handed things like washing your hair. The side that's more affected isn't really kind of doing that same movement. More difficulty with rolling over in bed, getting up from a chair. Reduced arm swing with walking. That's a common symptom people notice early on. Changes in the walking, more of that shuffled, kind of slow, stooped posture. Tremors, you can have both action tremor and resting tremor, although the resting tremor tends to be more prominent with Parkinson's disease. Drooling, and then stiffness in the joints, which represents that rigidity that we talked about. Now, not everyone will have all of these symptoms. You can have a variety and have some that are more prominent and some that are less bothersome. For example, not everybody with Parkinsonism or Parkinson's disease has tremor. So about a third of patients don't have any tremor whatsoever. So it can really be very different for each person. And then the last symptom is cramping and curling of the feet, the toes. So some symptoms that you may experience that are not as easily visible, so not necessarily the physical symptoms that a neurologist is going to pick up on exam, but are things that you experience. And we call these non-motor symptoms. So loss of sense of smell, and this can happen even decades before the physical signs show up of Parkinson's disease. A group of symptoms called autonomic dysfunction. And what our autonomic system does is it's part of our central nervous system that controls heart rate and blood pressure and bladder and bowel function, sexual dysfunction. So when this is impacted in Parkinson's disease, it commonly causes bladder changes, constipation, dizziness, because the blood pressure has a more difficult time maintaining kind of that normal homeostasis. Sleep issues, which we'll hear about from Dr. Hellman next, which include difficulty getting to sleep, sleepiness during the day, and then a special disorder called REM behavior disorder. Psychiatric issues, which we'll also hear about a little bit later, so I won't dive deep too much into these. Cognitive issues, that can be slowness of thinking, memory problems, multitasking. Those are common cognitive deficits in Parkinson's disease. Drooling, I put this on both slides. I guess I really wanted you to know about the drooling. Fatigue, pain. And again, these are all the non-motor symptoms of Parkinson's disease. So some tests that your doctor may order if this is a concern are simple blood tests looking at the blood count and how your liver and kidneys are functioning, any electrolytes. As these aren't usually a cause of Parkinson's disease, but can be worsening things. So we usually like to make sure that we're not missing anything else and just blaming it on the Parkinson's. We may look at your thyroid function, vitamin deficiencies, inflammatory markers that can sort of mimic or add to Parkinson's symptoms, infectious causes, and some rare metals. Now, if you didn't have all of these done when you were diagnosed, it doesn't mean that that was done incorrectly. We sort of make a decision about what tests we may get based upon your individualized circumstances. Another test we may consider is doing an MRI of the brain. Again, this is not something that you have to have had. It may be just dependent on your different circumstances, but it's a common test that we order. And when we get an MRI of the brain, we're not necessarily seeing the Parkinson's disease on the MRI. We're usually ruling out other things that could be mimicking Parkinson's disease. Another test that can be done, and I just want to make an emphasis that it's not something that you should have gotten or that everybody will get. I personally use this test called a DAT scan when things are not always clear, and we use it as an extra kind of piece to the puzzle that we're trying to figure out. But what this does, this DAT scan, it's a CT-based scan, and before you go into the scanner, we give you an IV infusion, and what that does is it goes in and labels dopamine. So when we scan the brain, what we can see is how dopamine is being taken up in this part of the brain called the striatum. And so you can see in this picture, the normal scan, you can see kind of that comma-shaped picture of the striatum. That is a normal uptake, and that's a brain that doesn't have neurodegenerative Parkinson's. On the other side is reduced uptake, and that would signal that that person would have a neurodegenerative Parkinsonism like Parkinson's disease. Now, there always is the potential for false positives and false negatives. It is a fairly accurate test, though, so if there's a question, sometimes we will get this test. All right, so what causes Parkinson's disease? So again, Parkinson's disease is a chronic, progressive condition that occurs because we lose dopamine in the brain. Now, at the bottom of that picture of the brain, there's this little area, a clump of cells called